Okay. I will cover two topics today: fluid management and the post-operative management. Post-operative management. The thing is, I will give a broad idea only because for the under the each and every topic like dysphagia and each and every surgery that you are studying, you will be studying the specific post-operative management. So no need to go into deep into that because you can understand properly under the each and specific topic. So on the topic, I will give a broad idea. Even we can skip that, but anyway, under the topic, I will give a broad idea. Fluid therapy, we will go through it, and this is a easy topic. So to say on the topic, regarding the fluid therapy and management, you won't be asked. You won't be asking to write a SEQ. That is very rare because in the past also there were no questions on SEQ regarding the fluid management. But frequently they are asking each and every year at least 1 or 2 questions on fluid therapy. So for the MCQ or the MCQ mean MCQ and SPR, it can be asked either in MCQ or SPR. So we will go through that. I will share the screen. See whether you can see that. Can you all see the slides?
Yes, bro.
Then we will start. This is easy topic. So if you understand the basic, you can easily work through the question. So I will go through the thing that but we have to cover while studying the fluid management. So what to study? First we already guys know this information. So I will go through it quickly. Water distributions. What is the distributions of the fluid within our body? We have to see that idea because on that idea they have asked 1 or 2 questions in the past. So there is high chance that they can ask in the future as well. And what are the types of fluid we can use while doing the fluid management in the ward or in the theater? And fluid therapy in surgery, specifically what are the fluids that we are using in the surgery. And finally, blood transfusion. I won't be talking about the blood transfusion because I have seen there is a specific class for you guys on blood transfusion. So no need to talk about the blood transfusion here. Okay. So this is the overall idea of the fluid distributions within our body. Just remember, this is the idea: 0.6 liter per kilogram. That is the rough way to calculate the exact total body water. 0.6 liter per kilogram. So here they have given as a 70 kilograms. So if you multiply that 0.6 into 70, that is they have given as a 42 liters. So actually how the distributions maintain is, first we can distribute our water into 2 compartments, intracellular and the extracellular. Intracellular means the fluid within our cells, the fluid out of the cell. So that is the main broad classification we do initially. So 2 out of 3 of the total body water is within the intracellular compartment. That is, if we calculated 42 divided 42 into 3, it will be 14. So 2 times is 28 liter. That is intracellular compartment. So 1 out of 3 is in the extracellular compartment, that is 14 liter. So extracellular compartment mean out of the cell. It can be anywhere in between cells or within the vessels or anywhere out of the cell is the extracellular compartment. So again, the extracellular compartment can be classified into further. That is intravascular fluid and the extravascular fluid. Intravascular mean that is what we call the plasma, which is there within our blood vessels. That is, if you talk in the ratio, that is 1/4, 1/4. That is the ratio, and the extravascular fluid is 3/4. So they have directly calculated and they have put the amount. So we have to know that the ratio. Here, I think you can see the cursor. 1/4, here 3/4. And also they have specifically classified again the extracellular fluid into interstitial and the transcellular fluid, but we don't need that. So just remember this classification up to extracellular fluid. So if you know that, we can answer the MCQ that have been asked in the past. I think everyone would have understood, but if there's any classification, just call me and ask. No problem. So these are the types of fluid we are commonly using in the day-to-day management. So I have compared the each and every fluid with the plasma, because we are trying to replace the plasma as much as possible. So that's what I have compared that. So the common one we are using in day-to-day life, that is 0.9% sodium chloride. That is we used to call normal saline. So that one. Another one is a Hardman solution. Hardman solution. Hardman solutions, we know that is more towards a physiological. Physiological mean that is same as plasma. Same as mean not exact same, but almost same as plasma. But there is another solution which is we call plasma light solution. That is actually the more physiological than the Hardman. If you compare the Hardman and the plasma light solution is the more physiological, that we have to know. Sometimes they may ask somewhere, or even in the long case discussion. So, but other than that, you have to know the amount of sodium and the chloride that the 0.9% sodium chloride mean normal saline contain. Because with that, using that, we have to do some calculation to answer some MCQ. So 0.9% sodium chloride mean that contain only the sodium chloride and the water, nothing else. No any other ion, no or glucose, nothing else. Only the sodium and the chloride. So, what does it mean is, if we take sodium chloride, if we take 1 liter of sodium chloride, in the word we are having the 500 ml, half liter of pack. But if you take 1 liter of sodium chloride, it contains 308 millimoles of iron, including sodium and chloride. Each of the iron is half of total. That means 154, 154. Total 308. This is the amount that the sodium chloride have in 1 liter of solution. So in our word, we are having 500 milliliter of pack. Each pack contains 500 milliliter of sodium chloride. So each will be having 77 ml of sodium and 77 millimole of chloride. So have you understood that? Just a calculation, nothing else. Okay.
Okay.
Because hello, Harini. Okay, I think yes. Other than that, we don't need to memorize other things. Sometimes I don't know whether they will ask in the long case, but that is more rare. So just remember the 0.9% sodium chloride that can be asked in the questions MCQ. There are a lot of MCQ on that. We will discuss at the end also. And just remember, plasma light is the more physiological solution to plasma compared to the Hardman. Okay, because plasma light solution is somewhat expensive and not freely available in our world. That's why we are using the Hardman solution. But if you compare Hardman and the plasma light is the more physiological. Okay. 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 That is first one we have seen the crystalloid. Then we will go to the colloid. Colloid, there are a lot of colloid. For example, albumin, dextran, hypoethyl starch, and the gelatin. But the commonly used colloid is the albumin. That day-to-day life we can see a lot of patients is given albumin. And also in the management of the dengue, at the stage of shock only, we can use the dextran. Other than that, we don't use dextran as well, and we rarely use the HES and the gelatin, because any colloid, even albumin, can lead to the hypersensitive reaction, allergic reaction, even into the anaphylaxis. And the second one is, these are these HES and the gelatin, even the dextran, are the molecule which has the high molecular weight. So they are a big molecule. So what when we use these solutions, they go into our body, and when they reach the renal tubules, they tend to block the renal tubules. So it can lead to the acute tubular necrosis. That is a common problem that common means that is a serious problem that we can get when we are using the colloid like HCS and the gelatin. So we don't prefer using this solution. We are using commonly albumin. We would have seen in a nephrotic patient. We can use albumin. Dextran, the only the place that where we use Dextran is the shock in the dengue fever. Other than that, there is no any other place we are using the Dextran. But other than that, both HCS and the gelatin, they are rarely used because of the side effect and the acute tubular necrosis. Okay, that if you know those, that is enough. If you have any question, ask me. Sometimes I may say wrong information. Okay, fluid therapy in surgery. So this is the most important thing. How are we doing the fluid therapy in surgery, even in the ward? So we know that we are using three components: maintenance, deficit, and the ongoing loss. Maintenance means in day-to-day life, we have to have a certain amount of fluid and the iron. That comes under maintenance. Even if there is a fluid loss or not, we have to maintain that fluid to a patient. Even not a patient, even a normal human being should take the maintenance fluid. That is one. Deficit means when there, for example, when there is a blood loss, if the patient have 1 liter of blood loss, that 1 liter comes under the deficit because the patient has already lost 1 liter of blood, so it will come under deficit. Deficit means he has already lost. The last one is ongoing loss. Ongoing loss means the patient is now bleeding. Like currently the patient is actively bleeding through the wound or something. So ongoing loss. Other than that, there can be evaporation. So there are several kind of mechanisms where the patient can have ongoing loss. So these are the three main components we have to make sure that we are doing the proper management when we are doing the fluid therapy in surgery. If my voice is clear, if there is any problem, just let me know.
Clear.
Thank you. And the fluid, the thing is the fluid management is more or same for the adult and the children, but the amount of the fluid management is somewhat different. So we will now study only about the adult, and we will see a question on one children as well. But here we will focus on the adult. Regarding the children, anyway, you will be studying when we are doing pediatrics, the diarrhea. So, but anyways, some students are only doing surgery. So that's what I have input the MCQ there. So I will explain how to manage dehydration in the children as well. But anyway, we will focus on the adult population because that can be only mostly asked in surgery question, and also it can be asked in a long case management if they need only. So we will focus on the adult. So this is the main. Wait for 1 second. Okay. So when we are this is the maintenance. Maintenance means in day to day, what is the amount of fluid the patient should take. So if you take a grown adult, the amount is 30 to 40 ml per kilogram per day. In each day per kilogram, he should take 30 to 40 ml of fluid. So other way, we can calculate in hour basis 1 to 1.5 ml per kg per hour. Okay, just remember any of this is okay. Children, I think you would have heard about this equation, but I'm not going to talk about this because we will see in the MCQ, but we would study in broad in pediatric management. So we will focus on the adult only. So when we are talking about the fluid management, we are not talking about only about the fluid, mean water. We have to also consider about the other ions. The most important ions that we have to consider are sodium and the potassium. So if you take the sodium, for adult population, the need of a sodium per day is 1 millimole per kilogram per day. Per day, per each kilogram, we have to replace 1 millimole of sodium. The children is 2 millimole. Oh, no need of that. The same for the potassium as well. For the adult, we need a 1 millimole of kilogram per day of potassium. That is sodium, potassium, and fluid for the maintenance therapy. Okay. So just to get an idea on how to calculate that, so we will see this question. Fluid and electrolyte in 60 kilogram ASA1 adult patient. So they are talking about the maintenance therapy. So we will calculate, we will take it, so here we have seen 30 to 40 ml. So we will take it as a 40 ml per kg per day. So the weight is 60 kilogram. So the patient needs 240 ml of fluid per day. So 1 millimole of sodium per kilogram per day. So into 60 millimole per day. Same as for potassium. That's it. How we calculate the fluid and the electrolyte to replace in a patient as a maintenance. So here usually in our ward or in our practical setting, we are commonly using 0.9% sodium chloride. So already we have seen 1 liter of sodium chloride contains 154 millimole of sodium, 1 liter. Here we are using a bottle of normal saline which contains 500 ml of normal saline that has 77 millimole of sodium. We have already seen that. So we need only 60 millimole of sodium. So that is enough to give 1 bottle of normal saline. Mean 500 ml of normal saline is enough to replace the sodium per day because it already contains 77. But if we give 1 bottle of normal saline, it gives only 500 ml of fluid. So rest of the fluid should be given as 5% dextrose. So how we replace the fluid? And we also need 60 millimole of potassium. So we will replace the potassium with a KCl vial. Everyone would have seen that. There will be the colorless vial which has a colorless solution as well. Each vial contains 20 millimole of KCl, I mean potassium. So we need 60 millimole. So we have to use 3 vials. 3 vials into 20. So we can replace 60 millimole of potassium. So each vial contains 20. So we will add each 1 vial into 1 bottle of 5% dextrose and we will replace that. Likewise, we can replace the maintenance fluid. So this is also calculation. So we have to know 1 KCl vial contains 20 millimole of KCl and 1 bottle of normal saline contains 77 millimole of sodium. No need to worry about the chloride. Okay, I think you would have understood. So if any clarification, ask me. So like what I say, rest of the fluid will be given with the 5% dextrose. Mean, so 500 milliliter of normal saline is gone. So rest is 1900 milliliter of fluid. So we will replace with a 4 bottle of 5% dextrose. So simple calculation. Because there are a lot of questions we will go through. So they have asked regarding this calculation. So ongoing loss, I have already explained that. So we can lose the fluid via the evaporation, bleeding, and if the patient is with NG drain or any other kind of drain, so with the drain, we can have a loss of fluid. So when we have replaced the ongoing loss, it should be replaced at 1:1 ratio. Mean if the NG drain has 500 milliliter of fluid, we have to replace with 500 milliliter of fluid. 1:1 ratio. How we are doing the ongoing loss replacement. Okay. And this is according to Anuja madam's lecture. In a patient who's come with a dehydration, how to calculate?
දෙන්නේ dextran ඒකට දෙන්නේ ongoing loss
dextrose 5% dextrose means sugar.
හරි.
Already I told dextran is a colloid. The only situation we can use the dextran in our practical setting is a dengue shock, hemorrhagic shock, whether it's a compensated or non-compensated. That is the only situation we can go for the dextran. Other than that, albumin we are using in a nephrotic patient in child ward, or some other situation we can use an albumin as well. Other than that, we are not using colloid like HES, gelatin we are not using nowadays because of the complication I have told. So the common colloid, if they ask the common colloid, albumin or dextran in a situation of dengue hemorrhagic shock. Other than that, we are not using the colloid because colloid is some problematic solution. It can lead into the side effect like anaphylaxis, and also it can lead to acute tubular necrosis due to the high molecular weight because they are large molecules. So we are not going for the colloid for the routine management. So the solution I have told is a 5% dextrose. Dextrose means that is sugar. Okay.
Okay, bang.
Okay. Okay, this is the deficit. How to calculate mild, moderate, severe. So we have to have the idea how to identify a mild dehydration, moderate dehydration, severe dehydration. Mild mean patients will be all right, and the patient mean I mean adult or children. For the children, you can see for the children and the adult regarding the severity of the dehydration, the percentage differs. So I think you have to remember that this percentage, then only you can answer. So just try to remember this. Regarding the mild dehydration, mild mean patients will be all right but thirst. So he will tend to drink more water. And otherwise, the vital parameters like blood pressure, pulse rate, capillary refilling time will be normal as a normal person. There will be not that much change. So otherwise patient will be okay, but there will be a certain amount of dehydration. So clinically, but patient will be okay. So that kind of situation we can take it as a mild. Moderate means there will be obvious signs of dehydration like sunken eyes. Patient will be having the change in the vital signs like the tachycardic heart rate will be goes up, and there will be reduction in the blood pressure, and he will be thirst to drink a lot of water at a time. So those kind of signs and symptoms will be there when there is a moderate dehydration. Severe dehydration means that is kind of a shock status. Patients is going toward a shock. So there will be a heart can't compensate. So there will be a dropping of the heart rate. In the moderate dehydration, heart rate will goes up to compensate the loss of fluid. But in severe, the heart rate will go down, blood pressure will be go down, patient's conscious status will be altered, loss of consciousness, or patients will be drowsy, he can't respond. Kind of features will be there in the severe dehydration. Those are the features they will be given in the MCQ as well to identify whether that is mild, moderate, or severe. We have to catch it. Then only we can answer the question. So when we see the MCQ, we can go through that. So you have to know how to identify mild, moderate, severe. If they are giving that the patient has lost some amount of fluid, but the patient is totally normal, then we can take it as a mild. Patient, there is certain amount of fluid loss. Patient is also compensating like tachycardic, tachypneic, and the blood pressure is dropping, and the patient is thirst to drink more water. Then we can take it as a moderate dehydration. So if nothing works, like patient is totally abnormal, like patient is conscious status is altered, like coma, so loss of consciousness, drowsy, and patient heart rate goes down, blood pressure drops severely, patient is not responding, or they are giving symptoms of shock, then we can take it as a severe dehydration. So this is regarding the dehydration, like diarrhea, severe vomiting kind of status. So you have to anyway remember this percentage. This is according to the Anuja madam's lecture. But I have seen some other lectures have given some other parameters, like percentage somewhat differs. But I think this is taught by Anuja madam, so I have given that percentage. So I think that's okay, ne? Just remember the percentage. So if you identify the percentage of the dehydration, then that's the end for the questions. So we can easily answer. So we have to, if they ask the questions regarding the dehydration, we have to find the percentage under which category the question is belongs to. If we find out that, then the rest of the question is easy. I think I take it as okay. Then we will move on. So this is to explain how to manage that. For example, this is not an MCQ question. I have directly given 60 kilograms severely dehydrated person. So 60 kilogram means we know that this is adult person, severely dehydrated. So we have to know the percentage. So for adult, severe dehydrations come, we can take it as 8%. So that is the point we have to identify. If you identify that, rest of the calculation is very easy. So here 8%. So we will we will answer the questions. Take it as a 8% of fluid loss. So how to calculate? For each percentage, there is 10 ml. So 8 into 10 into the body weight, 60. So if we multiply that, that is 4,800 milliliter of fluid loss. So in adult
what is 10 thing
10 mean for each percentage of fluid loss, we are replacing with 10 ml of fluid. So 1% means 10 ml of fluid should be given. For 8%, 8 into 10. So each percentage of fluid loss, we have to replace with 10 ml. Then hurry then. Hello? Can you hear?
Okay, okay.
Okay. So sorry, I didn't mention it. So each percentage, we have to take it as a 10 ml. So 8%, so 8 into 10 per kg. So we are multiplying into kilogram. So that's the total amount of water is 4,800. So the calculation of severely dehydrated, how to replace the fluid with, for the severely dehydrated patient in the children, according to the WHO guideline, is somewhat different. I think all can remember what we have studied in the diarrhea. That's somewhat different. But in a severely dehydrated person as an adult, we are managing it as a shock status. So this management is somewhat different for the management of severe dehydration in diarrhea, according to the WHO. You can remember that. We are going for that 100 ml per kg of kind of management. So I'm not talking about that. Here, as it is an adult person, we are managing it as a shock. So when there is a shock, how are we going to manage this? First, initially, we have to give 20 ml per kg bolus of the fluid. That is the first management. But whatever the kind of shock, we have to give the fluid bolus first. Specifically for the sepsis, there is a specific amount of fluid. For any other kind of shock management, we are initially giving 20 ml per kg. I think you would have understood. For severely dehydrated person, we have calculated the deficit. 8 into 10 into 60. So this deficit is 4,800 milliliter. Means he has already lost 4.8 liter of fluid from his body. That is what we have calculated at the top. How we are going to manage that is, first we are giving a fluid bolus. Any kind of shock in an adult person, we are managing with a bolus. Here 20 ml per kg. So we will initially giving 1200 ml of fluid. That is the first one. Then usually we are giving this 20 ml per kg over 10 to 20 minutes. Mean we are not just pushing all the fluid at once. We are giving it as a fast bolus over the 10 to 20 minutes of period. So after 20 minutes, we have to reassess the patient, whether his parameters has picked up or whether the parameters are going down still. So we have to do the reassess after 10 or 20 minutes. After giving this 20 ml per kg, means here in this patient 1200 milliliter of fluid. Mean almost 3 liters of normal saline. We have to reassess. If still the parameters are worse, then we can go for the second bolus. Here I have mentioned that we can go for the second bolus. Second bolus means again we can give other 20 ml per kg. Means again we can go for other 1200 milliliter of fluid. That is according to the assessment that we are doing after giving the first bolus. So here, this is a theoretical question. Theoretically, we will think that after the first bolus, patient is all right. His vital parameters are coming up. So then how are we going to manage the rest of the management? So already the deficit is 4,800. Already we have given 1,200. So the rest of the fluid is 3,600. The deficit. Still we have to replace 3,600 within 24 hours. Because already we have given the bolus of 1,200 ml. So the rest 3,600 should be given in a certain way that I have mentioned here. Half of the fluid should be given in the first 8 hours. The rest of the half should be given over the next 16 hours. Mean 1,800 in the first 8 hours. The rest of the 1,800 in the next 16 hours. Total of 24 hours packed. This is how we are going to replace the deficit. I am only talking about the deficit, nothing else. Okay, ni?
Dextrose ne denne banne
Method, no. Here we are. This is a severe shock kind of shock management. No? Then we have to go for the normal saline, 0.9% sodium chloride. The dextrose katawa I told for the maintenance. This is deficit. Deficit, like when a patient comes with a severe bleeding, there is no blood pressure, then how are we going to manage in a ward? That kind of management, this is severe dehydration. So we have to replace with the 0.9% sodium chloride, normal saline. I think you would have understood that name. If anybody have doubt, just ask me. Sometimes the calculation may be confusing. So if you have any doubt, just ask me. I will tell again. No issue. And currently, there is a theory, there is a practically how we are approaching. This is kind of calculation. If there is a deficit, how we are going to manage. This is theoretic management. But how currently we are managing a patient is a goal-directed therapy. Goal-directed therapy means, no, I haven't mentioned that. Goal-directed therapy means we are managing the patient according to the patient's vital parameters. So when patients coming with the dehydration, so we will connect the patient to the cardiac monitoring and monitoring the blood pressure, pulse rate, respiratory rate, capillary refilling time, everything. And while watching the monitoring the vital parameters, we will give the fluid to achieve our target. That is mean by the goal-directed therapy. So if someone asks about any kind of fluid management, you can mention this word. We have to ideally manage the patients according to the goal-directed therapy. Mean the goal is the parameters. The blood pressure should be more than 65. Mean blood pressure should be more than 65. Heart rate should be less than 100. Kind of goal we are targeting. That is mean by goal-directed therapy. Some consultant may like this word, goal-directed therapy. If anyone have any doubt, just ask me. No issue. But this is only the calculation. We will go through the MCQ later. Okay. This is nothing to worry. Regarding the potassium management, I think it won't be asked in the MCQ SPRs. Rarely it can be asked in the long case management as well. If we take the potassium is a severe irritant to the vein. So we can't give the potassium through peripheral line as we are giving the normal saline in the ward. So maximum potassium we can give through the peripheral. Peripheral line mean I am mentioning our normal cannula is 100 millimole per day. More than the 100 millimole, we can't go through the peripheral line. Peripheral line mean the normal cannula. This is the maximum. If you want to replace it more potassium, more than 100, we have to go for the central line. That just keep it, remember. Okay. But I think rarely you can be asked on this topic. Harini, I think you would have understood that. Dextrose. We used to add into the dextrose and we will give as a total dextrose solution. Usually each vial contains 20 millimole. So we will add to the 5% dextrose solution and we will give it as infusion. Like that, 5 vial can be given through the peripheral line. 5 vial contains 100 millimole. If we go for more than 100 millimole, it will be irritating the veins and it can lead to thrombophlebitis. So we are not doing that. If we want to go for more than 100 millimole, then we will be going for the central line, CV line. That is a practical question. Sometimes they may ask in a long case, but that is very rare. So I have put it as MCQ point, no, nothing. Okay, ne?
අඩෝ මේ මචං ඒ දන්න දින ආන්නේ මම මේ ඒතකොට දැන් ඔගේ වයර් දැන් හතරක් පහක් දෙන්න ඕන නම් ඒ ඩෙක්ස්ට්‍රෝස් 500ට එක්කම ටික දාලා එහෙමද දෙන්නේ?
ඔය එහෙම තමයි දෙන්න. We can't directly give potassium. That is severe irritant for the veins. So we can't do that. We are adding into the dextrose solution and we are giving into the body.
ඒ කියන්නේ වයර් 3-4ක් වුණත් we can add to the one dextrose packet නේ?
No. One vial should be added into one packet of dextrose. If you want to give 3 vials of potassium, means 60 millimole, we have to use 3 bottles of dextrose. Okay, ne?
Okay.
If you want to go for more than this amount, we will choose a CV line. Okay, thanks for the question. Okay, then we will move to the MCQ. I think you will understand what we have studied here. Here, first question is regarding the burn. I am not sure that whether you are guys having a separate lecture or topic on burn. So have you studied any class or any batch on burn?
இல்லடா அப்படி burn-ல நடக்கல செப்பரேட்டா.
So that's what I have put this question because sometimes you may have a class in the future on burn, so you will study thoroughly. But anyway, I am not sure whether you will be having a class. So this is one of the important topic, the Parkland formula. So then we will talk here. The question is: a burn patient weighing 50 kilograms sustain a partial thickness burn of 30% body surface area. What is the amount of fluid that should be given within first 8 hours of injury? So here the management of a burn patient. So when there's a questions regarding the burn, they will be giving percentage of the body surface area. So 30%. Otherwise, you have to know how to calculate the body surface area in the practical management. You know that the chest area is 8%. Now you know 8% is something. There's a calculation. I have also forgotten that. Practically, we have to calculate that. But in the questions, mostly they will be giving the exact percentage. But here they have given 30%. The weight of the person is 50 kilograms. So they are asking what is the fluid and how much of fluid should be given within the first 8 hours. So the answers you can see Hardman, all are Hardman. But the problem is in actual MCQ, we won't be having this kind of answer. Some 2 or 3 answers will be other kind of fluids like normal saline or dextrose. So kind of any other kind of answers also will be there, but here all the answers are Hardman. So Hardman is the ideal solution because I have already told Hardman is somewhat towards physiological towards a plasma. The best physiological solution is the plasma light. That is the first one. The next to the plasma light, Hardman is the more physiological. So Hardman is the best solution to replace. So Hardman. So all the answers are correct. Then we have to calculate the exact amount what to replace. For that, the formula we are using is the Parkland formula. This is the Parkland formula. So in different books, they have given different ratio of the fluid. But just remember 4 milliliter per kg per body surface area. That is the exact formula. Some book has given, I think, one emergency book has given 2 to 4 ml per kg. So here the problem is even if you take 2 or 4, both the answers are here. So that is somewhat confusing. So just take it as 4 milliliter per kg per body surface area. That is the amount of fluid we have to replace in a burn patient within 24 hours. That is the formula called Parkland formula. So if you know that formula, you can answer any question. I think I have do the calculation. So 4 ml per kg per body surface area. So 4 ml into the body weight is 50, 50 into body surface area 30. So if you calculate that, the total amount will be 3000. That is the total amount. 3000 should be replaced. But what they have asked is what should be given within first 8 hours. So how we are going, the total fluid is half should be given.
3000 Sarjan.
No,
6,000
per
kg.
Sorry,
6,000.
The total fluid should be given is 6,000. So what they have asked is 8 hours of first 8 hours. Half of the fluid should be given in the first 8 hours. Rest of the fluid should be given in the next 16 hours. That is a way of replacing the fluid in the burn patient. So half of the fluid mean 3000. 3000 should be given in the first 8 hours. The rest of the 3000 will be given in the next 16 hours. Total of 6000 milliliter of fluid in the 24 hours. Understood that? Any question? I haven't mentioned the calculation, sorry, but if you calculate that, the total amount of fluid will be 6,000. So half of the fluid should be given within the first 8 hours. So that is 3,000. That's what they are asking. Sometimes they may ask what is the total fluid. So sometimes they may ask what is the fluid should be given in the next 16 hours. So they can modify the question. But the concept is, this is the concept, Parkland formula. If you know the formula, that's the answer. So anyone have any doubt? I will take it as a no. Sometimes you may have a class on burn, I'm not sure. Thinking that sometimes you may not have, I have given this question. Just remember the Parkland formula, 4 ml per kg per body surface area. The second question, 40 years of old man presented with features of acute abdomen. On examination, hypotension, tachycardia was present. 1 liter of normal saline administered after 20 minutes. What is the fluid distribution? Can everyone see the slides?
Yes.
Yes.
Here they are telling about a patient who comes with acute abdomen. They didn't mention about the cause. Anyway, acute abdomen. On examination, hypotension and tachycardia. So the patient is, the condition is somewhat worsened. So 1 liter of fluid they are giving. 1 liter of normal saline means 0.9% sodium chloride they are giving. After 20 minutes, what is the fluid distribution? So after giving the 1 liter, where will be the fluid? That's the actual question. So they have given a lot of answer. Here we have to go back to the slide. Here. This is the slide they are asking the question on. Nothing else. So 1 liter of fluid they are giving. That's the question. So 1 liter fluid where we are giving? We are giving into the vessel, blood vessel. So that is an intravascular compartment. So once we give the fluid into the intravascular compartment, first it will be distributed into two. Some amount of the fluid will be stayed in the intravascular compartment. Some will go out. So that is within the 20 minutes. That will mostly happen. Some amount of the fluid will be there within the vessel. Some will go out. It can go anywhere. Mostly it will be out of the cells. Some amount of the fluid even can go into the cells as well. But we can hear that in the question we can take it as if we are giving the fluid into the blood vessel, some amount will be within the blood vessel, some will move out. So here they are directly asking the ratio of this one, intravascular and then extravascular. We are totally giving the fluid, some will say intravascular, some will go out. So 1/4 will be stayed inside, 3/4 will go outside. Nothing else will happen within that 20 minutes. If we take 24 hours, then the fluid, the 1 liter will be distributed all over the body. like some would have moved into the cells, some will be within the blood vessels, some will be within the cells. That kind of distribution would have happened if they have given us a 24 hours. But here they have asked only 20 minutes. Just 20 minutes. Now they have just given 1 liter of fluid. So some amount of fluid will be there within the vessel, some will go out. So inside the vessel there will be 1/4, 3/4 will be outside. So if we calculate that, 250 ml will be within the blood vessel, 750 will be outside the blood vessel, mean extravascular fluid. That is the question they are asking. So there are a lot of answers. So the answer is 250 ml remain in the intravascular compartment. The small trick they have used is we have to think that they are giving the fluid within the blood vessel, because at the first slide we have studied the total distribution within a normal person, how the total fluid is distributed. But here the question is they are actively giving the fluid into the blood vessel. So some amount will stay there, some will go out. So we have to think that and approach this question. Then there will be the answer directly. 250 ml remain in the intravascular compartment. 750 will be extracellular. There's no answer like that. So the answer is B. Have you all understood that?
Yes, sir.
Yes, I think others also would have understood that. So that's the point. If you wrongly take it as a total from the first point, that like if you going to distribute from the total body, then there will be no answer. We will be totally confused. So that's what they are giving 1 liter of normal saline administered. So we have to know normal saline means it should be given into the vessel, nothing, nowhere else. So we have to think within the blood vessel, outside the blood vessel. Within the blood vessel 250, outside 750. Because I am doing so simply because they have only mentioned 20 minutes. For the distribution of the fluid to go into the cell and other places, it will take a long time. So just think, we are giving 1 liter of fluid to maintain the blood pressure. So if the fluid is distributed all over the body, we can't maintain the blood pressure with the administration of our management. So that's what, when we are administering the fluid, mostly it will be stay within, some will stay within the vessel, some will go outside only. It won't have the time to move into the cells within 20 minutes. So if we find the point, then there's the answer. Easy question. Okay, so this is the answer. Okay, the third one, any doubt, ask me. 50-year-old male with ischemic heart disease is to undergo emergency laparotomy. His weight is 60 kg and pre-surgical hemoglobin level is 9 kg per deciliter. The expected amount of blood loss during first hour is 1100 milliliter. What is the best fluid to give? So we sometimes may confuse, but the point is, when there's a blood loss, the best fluid to replace is the blood, nothing else. We have studied the Hartmann or the plasma lead, which are more physiological, but they are more physiological towards the blood, nothing same as blood. So whatever the circumstances, if we lost the blood is the best solution to replace. But why we are not doing at the ward is because we need time to cross match the blood. Because we know that we have to first cross match and then we have to give the blood. Otherwise we can't start with the blood. That's what initially we are giving Hartmann or normal saline or whatever the fluids we are having. Once we cross match the blood, then we will start to replace with the fluid. Blood transfusion will be started. Here they haven't mentioned about any situation. They are asking this amount of blood is lost, but can be replaced as best fluid. So we have to think that everything is available, cross-matched blood is available, then we have to go for the blood. So the answer is packed red cell. Nothing to think much. None of any answer can come for this question other than the red cells, packed red cells, mean there is blood. Okay, the point is, when there's a blood loss, the best solution to replace the blood loss is the blood, nothing else. But we are not doing practically at the initial of management because we don't have the cross-match blood to give. It will take at least 20 or 30 minutes to get the cross-match blood. Once we get it, we will start doing the blood transfusion. Okay. So the answer is packed red cells. They are meaning the blood. I hope that you have understood. Then we will move to the next question. Then this we will look at this question later after doing the post of management. Okay, we will leave the questions now. Here, I think this is the last one. Sorry. This is the this is the last question. So, 5-year-old boy with body weight of 20 kilogram presented with features suggestive of adhesive intestinal obstruction. He complains of thirst and there is dry mouth. Pulse rate is 80, and they have mentioned the normal range 80 to 100. Systolic blood pressure is 90, that is normal. His investigation results are as follows: serum sodium 140, serum potassium 4, all are normal. Chloride is low. What is the best fluid therapy for the next 24 hours? So we are asking the management for the 24 hours. For this kind of question, I have already mentioned we have to identify what kind of fluid loss that the patient has gone through. Because intestinal obstruction means patient would have gone severe vomiting. So there should be a certain amount of dehydration. What kind of dehydration this is? Mild, moderate, or severe? If you find out that, then we can easily answer the question. So they have mentioned thirst and there is dry mouth. So dry mouth, thirst, and pulse rate is normal. Blood pressure is anyway normal, but there is a dry mouth. So here we can take it as a moderate dehydration, not a severe, not a mild one. So we can take it as a moderate dehydration. Then we can go for the answer. So for that thing, for this kind of questions, I already told you have to remember the exact percentage. So if you don't know the percentage for the certain age of population, we can't go for the answer. First, we have to identify the percentage. For that, we have here identify the moderate dehydration. For the moderate dehydration, at the age of 5, we have to know the percentage. So that is a 10%. If you go back to the chart, you can find out. Again, I'm telling that is according to the Anujas Madam lecture. So in some other notes, you may find other percentage, but I'm not sure about that. This is according to the Anujas Madam lecture. So 10%. So when we are going to do the management, we have to consider two things: maintenance and the deficit. And if there is ongoing loss, we have to replace the ongoing loss. Already I have told that is 1:1 ratio. If his vomiting is a 50 ml of fluid, then we have to replace 50. So that is a different part, ongoing loss. So the routine management, we have to do the maintenance and the deficit. So that's what I have meant, fluid equal to maintenance and the deficit. Hello, Vishwa. Okay, then we will go. We'll continue. So to calculate the maintenance, I think you have to see this. I didn't spend a lot of time. This is because that is children. So we would have studied thoroughly in dehydration management in the diarrheal children. So that's what I didn't spend a lot of time. So this is how to manage severe how to calculate the maintenance fluid in a children. So we know the first 10 kilo 100 ml per kg per day. Second 10 kilos 50 ml per kg day. And for the rest of the 10 up to 50 kilogram, we have to give 20 milliliter per kilogram per day. So just go through these numbers. Then you will identify how I am going to do the calculation. This is the thing I have used here. Okay. So they have mentioned the body weight of the children is 20 kilogram. So the first 10 kilogram, 100 ml per kg per day. So the question is also the best fluid therapy for the next 24 hours. So we can calculate for the per day. So if we calculate for the 20, that comes as 1500 milliliter per day. That is maintenance. Then we have to calculate the deficit. Deficit we already know that is 10%. No, I think I have taken it as 5. I have made a mistake. Sorry, this is more than 1 year's name, so the percentage is 5. Sorry. So I have mentioned in a wrong way. This is not 10. This is 5%. Sorry, guys. So if it takes as a 5%, for each percentage 10 ml, 5 into 10 into body weight 20, that come as 1000 milliliter. So adding maintenance and the deficit, total fluid that should be replaced within a day is 2500 ml. So that fluid we have calculated that here 2500. Then we should know with the fluid we always should be aware of sodium and potassium. As this is a case of child, sodium is 2 millimole per kilogram, where in adult 1 millimole per kilogram, both the sodium and potassium. In children, that is both sodium and potassium should be 2 millimole per kilogram into 20 per day. So that is 40 millimole. That is all the calculation are per day. So we know one bottle of normal saline contains 77 millimole of sodium. So to get the 40 millimole, 250 ml of normal saline is enough. Have you got my calculation? Any question?
Saru.
Oh.
In this child, the sodium levels are in normal range, ne?
Normal range. The problem is maintenance. We have to anyway give the maintenance fluid now. Maintenance should include fluid, sodium, potassium. Because if we give the fluid only without sodium, potassium, that will lead to hyposmolar state. Because sodium concentration will automatically goes down due to the pure fluid. So when we are doing the management, maintenance should always consist of sodium, potassium. So to get the 40 millimole of sodium, 250 millimole of normal saline is enough. So when we deduct the 250 from the 2500, rest is 2250. So the rest of the fluid can be given as 5% dextrose. For the 40 millimole of potassium, we will be adding 2 vials of potassium chloride into the 5% dextrose. That will be the exact management, the theoretical ideal management for this child. Yeah. So if you come to the question, they have given a lot of answer. We know 250 ml of normal saline with 2250 of dextrose with 2 vials of potassium is needed for this child. So which is the answer? Hardman solution 1300, not enough, because fluid should be, there should be 2500 ml of fluid. Second answer is also wrong, because there's a deficit of fluid. The third one is normal saline 5% dextrose with KCl 1500 ml. That is wrong. We know 5% dextrose should be 2250. The answer D is also wrong, because we have to replace the fluid with sodium chloride and the dextrose. So the answer which is close to the exact answer is the E, because they have mentioned intravenous 0.45% sodium chloride with 5% dextrose with KCl, 2500 ml. It is almost near to the 2250. That's what I have taken as an E as an answer. But the ideal answer is this. 250 of normal saline, or here, according to them, as it is 0.45%, it will be 500 ml of fluid, normal saline, according to this percentage, with 2250 milliliter of 5% dextrose with 2 vials of potassium chloride. That is the ideal exact management should be given for this child. So just I have given the answer because this is most close to our ideal answer. So I have taken as a E. Sometime in the real paper there may be a different answer. So we have to know the fact and how to do the calculation. Okay. Hello.
0.45 එකකින් දුන්නාම එතකොට double කරලා දෙන්න 500 දෙන්න.
Oh, because we have calculated the 250 for the 0.9% sodium chloride. So if we are using 0.45%, we have to give 500 milliliter of fluid. So we will be giving rest 2000 as a 5% dextrose. Your one is correct. Okay, ne?
Rest 2000.
Yeah.
So
first we have to which potassium chloride. Your voice is not clear. I think you're asking about the potassium chloride. Potassium chloride, this is the way. Potassium chloride, each vial contains 20 ml. So one vial can be given in one vial of one bottle of 5% dextrose. So we have to add 2 vial into 2 different 5% dextrose bottles. So there will be 1000 ml of dextrose with added KCl. The rest of the 1000 milliliter of 5% dextrose will be without KCl, and 500 ml of Harini. So if others also, if you have any doubts, because this is total of calculation, nothing else. If we know the exact formula, rest is calculation. Okay, nothing to think a lot. So if you have any doubt on the calculation, just ask me. Like here, because they have, I don't know why they have mentioned 0.45%. So if you take it as a 0.45%, we have to just change this amount. That's what I have told. If you take it as a 0.45%, 250 will be 500. And so after deducting the 500, the rest fluid will be 2000. Because the total fluid is 2500. That's what I have explained now. I think you would have understood. This is the end of this topic. There is no SEQ on that. Rarely it can be asked this kind of calculation in the long case. Only you will be asked in the MCQ for SBR. So that is the end. Then we will quickly go through this one, which post-operative management. Okay. I will share the screen. This is my notes I am sharing because I haven't prepared the slide, because no need of preparing the slide. We can finish it in 15 minutes. So can you all see this? Hello? This is the thing already I mentioned. Post-operative management is a specific management. It should be specified for the specific surgery. For example, if you are doing the colectomy, like Hartmann procedure or total colectomy, each kind of procedure should be followed a specific post-operative management. So here we can study specifically for each kind of surgery. So I will give a overall broad idea. So just keep it in the back of the mind. And when we are studying each kind of surgery, like esophagectomy, there will be specific post-operative management. Colectomy, thyroidectomy, like each kind of surgery, there will be specific management. So just keep it here in the back of your mind and apply it when you are studying specifically for specific management. So any patients coming after the surgery, we know that we have to monitor the vitals: blood pressure, heart rate, pulse rate, respiratory rate, temperature, input, output chart. If the patient is having drain, the output of the drain, and in certain situations, certain complications should be monitored, like post-thyroidectomy, stridor. So this is one example I have mentioned that. Like that, for each and every patient, vital parameters should be monitored, including temperature, input, output, drain. That is a must for any kind of surgery. I am talking about the major surgery, not a minor surgery. This all I am talking about the major surgery. And the positioning of the patient should be head up, because to prevent the aspiration pneumonia, so patient should be in the proper position. So this is the positioning of the patient. Then the most important thing I have is mnemonic fast. First one, the F mean fluid and feeding. How to start fluid and feeding? If the patient has undergone a general anesthesia, once the patient comes to the ward, immediately we can start the fluid management, oral fluid. So initially we will be starting the IV fluids, normal saline will be given. Then once the patient's recovered completely, thoroughly from the general anesthesia, then we will be slowly starting the oral fluid. We will be initially giving a sip of fluid, and we will watch the patient is tolerating the fluid. I have mentioned 10 ml. Yes, 10 ml is enough. We will be giving 10 ml of fluid. Then we will be watching the patient whether the patient is tolerating, whether there is vomiting, whether there is any kind of abnormality. So if everything is normal, then we will be continuing the oral fluid. After starting, after a certain a period of oral fluid, then we will be starting the semi-solid. After that, we will go into the solid. This is a broad idea how to start the fluid. So here again, I have managed, while we are giving the IV fluids initially, how to give the normal saline and the potassium and the sodium. That is to do the maintenance management, maintenance fluid management. We have thoroughly studied about the maintenance fluid management. So no need to repeat here. And the analgesic, there are the list of analgesic we can use. I have mentioned some: oral paracetamol, oral diclofenac sodium, suppository, IV morphine, epidural, IV paracetamol. IV paracetamol is a good analgesic, but due to the lack of availability, we are not using frequently in our ward. But IV paracetamol is a good analgesic. Okay, just remember. And the antiemetic, not every patient need antiemetic. The patients who are undergoing surgery which are high risk for the vomiting, like retinal surgery, laparoscopic surgery, or patients who are more risk of having vomiting, then we can go for antiemetics, not in every patient. Just we have to have an idea that we can prescribe antiemetic, oral domperidone or IV ondansetron, according to the tolerability of the patient. And the antibiotics, not in every patient. If the patient need antibiotics, then we will go. Already I have taught about the different type of surgery. If the surgery need antibiotics, then we will go. For the sterile surgery, we are not going for the antibiotic. Like thyroidectomy, no need of surgery until there is unless there is a specific indication. Then a spirometer. So we know that incentive spirometer is used for the pulmonary rehabilitation. It's not stable. I know that.
Antibiotic part clear.
Okay. Antibiotics mean antibiotics not in every patient. Under each category of surgery, you will be studying specifically. So no need to remember my this thing, because I have given a topic to do the post-operatives. That's what I'm giving an overall idea. Antibiotics, if it's specifically indicated only, we will be using the antibiotic. And spirometry, incentive spirometry, you have seen that 3-ball thing that the patient asked to use before and after surgery. That is in the purpose of pulmonary rehabilitation to increase their lung capacity and their ventilation and to prevent the aspiration pneumonia. That is the main thing of spirometry. Other than the spirometry, we can also use steam inhalation, chest physiotherapy. Those are the things can be used. Not in every patient. Spirometry is usually used in each and every patient. Steam inhalation, chest physiotherapy, if we think that we need that, we can go for that. And T mean fast. If we have done analgesic, we have done A, and S. T means thromboprophylaxis. Thromboprophylaxis, we can use stockings, and also we can go for prophylactic enoxaparin. So that is according to the indication and the preference of the consultant or surgeon. So we can go for anything, but the efficiency is high for the enoxaparin injection compared to the stockings. But anything we can use. But anyway, if the patient has a high risk of thromboprophylaxis, then we will be going for the injection of enoxaparin. So I have already taught about the dose and everything, the preoperative preparation. Just go through that. And other thing is hug. We know that every patient should be monitored properly for hypertension and the glycemic control and the gastric ulcer prophylaxis. That is a common thing. And if the patient needs investigation, we have to do the special investigation. That's why I told this post-operative management is specified to specific surgeries. We can't study a common theme for that. So each and under each and every surgery that you are studying, you will be studying specifically. So no need to spend a lot of time on this. Just have an overall idea. Then apply that overall idea when you are studying the specific surgeries later. Okay. Okay. Then the post-operative pain management. So if you are interested, just study the pain pathway and everything. No need to remember everything. Consequences of pain, just I have mentioned is for the theory. I will share the slides anyway. If you need, just go through that. So there are a lot of problems if we don't manage the pains. So I have mentioned a lot of things. Just go through it if you have a time. And the assessment of pain, sometimes in some cases they may ask. So as a general question. So there are a lot of ways to assess the pain. So numerical pain scale, we know that we give this patient a scale and we have to ask the patient to give a scale. And also mentioning 0 mean no pain, 10 mean the worst pain the patient had ever in the life. For the mothers, it may be a pain during the labor. So kind of giving example for the 0 and 10, and we are asking the patient to mention any number. And the visual analog, so it will have the face. So they will look at the face and give a face, the red or green. So kind of and the verbal rating. So just we will be asking verbally. And this is the WHO pain later. And no need to remember everything, just have an idea. If they ask, just mention this. Okay. No need to remember. They won't be asking. Even the MCQ, SEQ, anywhere, they won't be asking. This is for the knowledge. Okay. So I think we don't need that. If you need, just go through the notes. I will share anyway. Analgesic preoperative analgesic management. I have already taught in. I have taught in preoperative management. So I will skip that. Intraoperative, we have to have some idea. For the intraoperative, local anesthesia is a good one to for the pain management. That's what before putting the incision, we are giving the local anesthesia at the local area. That will have a good pain relief at the surgical site, even after the post-operatively. It is proven. So that's that one. And diclofenac sodium suppository, you know, after the initiation of surgery, some may insert diclofenac sub. So that have part. And the epidural, So we know that epidural is now emerging pain management. So we can keep this for 3 days. We can start it pre-operatively or intra-operatively, and we can continue post-operative as well. But the problem is we can't keep the epidural for long period because it has a high risk of infection. It will spread the infection into the central nervous system. So after 3 days, anyway, we have to remove that. And we know about the IV morphine we can give, and IV fentanyl. It will be relaxing the muscles as well. So that is also good type of analgesic. So we know that morphine is, when we are giving the morphine, it can lead to low blood pressure and the respiratory distress. So we have to monitor the vitals, the patient. Anyway, the patient who are undergoing surgery will be monitored, and we have to get ready with the antidote, naloxone. And some of us would have seen the plexus block. In certain kind of surgery, they are giving the plexus block before going for the incision. So that is that also give effect of post-operative and intraoperative management. So usually in the thyroidectomy, they are giving. So other surgeries also they are giving. So I have mentioned one example. And abdominal plane blocks are one important thing. Those are the intraoperative pain management we are using. Not only this, there are other pain management as well. Even the pre-operatively talking with the patient, explaining the patient also comes under the pre-operative pain management. So I haven't mentioned that. Just keep it remember. When you are discussing in the long case management, just mention those also. Giving a better understanding of the surgeries also release the pain. And the post-operative, again, just no need to remember that there are several options. So we can use that. And I have mentioned something about the pain in the amputation. So the post-amputation pain, there can be several type of pain. First is a stump pain. Stump pain means after removing of the stump, there will be the local pain for a certain period of time. That will be a sharp, severe aching pain. So we have to go for morphine kind of analgesic for that. And the neuropathic pain due to the damage of the nerves. So we have to go for gabapentin, amitriptyline kind of analgesic. For the neuropathic pain, you know that for the neuropathic pain will be there for long period. So it should be managed with kind of analgesic like gabapentin. And the phantom limb pain. Phantom limb pain means patients feel the pain though the stump is amputated. There is no leg, but still the patient is feeling a pain coming from the amputated leg. So that kind of pain is called the phantom limb pain. So that is a burning type short episodic pain. So those are the kind of pain the patients who underwent amputations can have. Sometimes you may study it again when you are doing peripheral vascular disease. So, but anyway, I'm mentioning this. And the reasons for the persistent stump pain, it may be infections or neuroma formation, or inadequate pain management also can lead to persistent stump pain. Okay, so that is the overall idea I'm giving. If you won't just go through the note, but under each and every topic you will be studying specifically. Okay, if anyone have any regarding the pain management, so other than that, if you have any doubt, just ask me. Then we shall do. Okay. I will tell the concept also here. That's what I didn't specifically mention anything regarding this question. 60 kilogram man with 10 centimeter laceration on his right forearm. What is the most suitable local anesthesia to suture the wound? Here we have to know.
Could screen the
sorry. Now is it okay?
Okay.
Okay. So this is the 60 kilogram man with 10 centimeter laceration on his right forearm, just a wound. What is the most suitable local anesthesia to suture the wound? So there is a wound on the right forearm that they are mentioning 10 centimeters, 60 kilogram. That those are the unwanted thing for this question. What is the suitable anesthesia, local anesthesia we need? For that we have to know two concepts. There is this question on. First, when we are using the local anesthesia, we are using the lignocaine. Usually we are using the 1% of lignocaine. So when we are using the lignocaine, it can be there with adrenaline, without adrenaline. That's a different one. There are bottles with adrenaline, without adrenaline. So if you are going the lignocaine with adrenaline, we know lignocaine has the action of analgesia. Adrenaline causes vasoconstriction. So if we are giving the lignocaine with adrenaline, what adrenaline do is it goes for the vasoconstrictions of the nearby vessels. So the injected lignocaine won't go outside. So it will stay at the local area. So if you are giving at the right forearm, it will be staying for a long period at the right forearm without going anywhere else because of the action of adrenaline. Adrenaline constricts the blood vessels. So blood vessels are constricted, no way for the lignocaine to go out. The problem with the lignocaine is when the lignocaine go into the circulation, it can cause a lot of side effect. So that's what we don't prefer huge amount of lignocaine for the injection. There are a certain amount of lignocaine we can inject. So when we are injecting the lignocaine with adrenaline, we know it won't be going into the systemic circulation because of the vasoconstrictive effect of adrenaline. So we can go for the higher dose, 7 milligram per kilogram. Without adrenaline mean we are not using the adrenaline. So when we are injecting the lignocaine, certain amount of the lignocaine will be going into the systemic circulation. So it can have lot of side effects, specifically the cardiac side effect. It can cause arrhythmias. So when we are using the lignocaine without adrenaline, we can only use 3 milligram per kilogram, lower dose. That is the concept we have to understand. If we know the concept, we can answer any question. Okay. So let's see the question. Usually I already mentioned 1% lignocaine. In medicine, 1% means 1 gram in 100 ml. Anywhere. What are the circumstances you study? 1% means 1 gram in 100 ml. Here is also the same. 1 gram of lignocaine in 100 ml of solution. Here what they are mentioning, I have mentioned this. So what is the indication of lignocaine with adrenaline, without adrenaline? Everyone knows that if we are using lignocaine in a place with end artery, we have to go for without adrenaline. Like a place at the tip of the nose, the tip of the fingers, because those are the places which have the end artery. So if we put adrenaline at those areas, it will go for the vasoconstriction and it can lead to the gangrene. So the place undergo necrosis and it can be dead. Like the tip of the nose and the tip of the fingers. So because they are having the end arteries. So those are the places where we can't use with adrenaline. Any other places other than this, the places which have end arteries, we can go for lignocaine with adrenaline, 7 milligram per kilogram. Here, according to their question, they are using on the right forearm. So right forearm doesn't have an end artery. So without any doubt, we can go for with adrenaline. That is the best option. Okay. So we will do the calculation for both. We can go for the with adrenaline. With adrenaline means 7 milligram per kilogram. So 7 milligram into weight is 60. So 420 milligram. So I have already told you that 1 gram in 100 ml. So if you do the calculation, it will come as a 42 ml. So we can go up maximum of 42 milliliter of lignocaine with adrenaline for this patient for the suturing. But I don't know, they have not given the exact answer, because according to the situation we can go for with adrenaline. But if we calculated the other one without adrenaline, that is 3 milligram per kilogram. So into 60, 180 milligram. So we can go for 18 ml. So that is the answer they are giving. 18 ml of 1% lignocaine. but actually it should be the answer. 42 ml of lignocaine can be used. But anyway, they have taken as a 3 milligram per kilogram. They have given the answer. Sometimes the answer may be, the question may be different one. I don't know. For this question, we will take as answer as A. 80 ml of 1% lignocaine. Here we have calculated of 1%. If the percentage is changed, we have to change the answer. Like 2% means 9 ml of 2% lignocaine. Likewise, we have to change them. Bupivacaine we are not using as a local anesthesia. Lignocaine is the one we are using as a local anesthesia. I think anesthesia part you are studying different, separately, ne? Yes or no? Are there any bed separately for anesthesia? Hello? Hello? I don't know whether you are having
எனக்கு தெரியலடா எனக்கு நான் நார்மல் எனக்கு இவங்க என்ன படிப்பிக்கிறான்னு வழிய தெரியல ஆனா லாங் கேஸ் மட்டும் தான் போயிருக்கு அது வந்து ட்ரோமா பெட் பீடியாட்ரிக் சர்ஜரி மற்றது உண்ட ப்ரீயோ போஸ்டம் அனஸ்தீசியா கண்ட விகாரமட மேனேஜ்மென்ட் எலெக்ஷன் நோட்ஸ் தானே
okay
அதுக்கு
I'm not sure guys whether you are having separate bed for the anesthesia part. These are the some points that we have to know regarding the anesthesia. So I will check it and I will let the committee to have a small session on the anesthesia. Like we can also we have to study what percentage we have to use. Like lignocaine, there's a other certain amount. Just remember this what I have taught for this moment. If you want, we will talk it later. Talk about this one anesthesia later. That's the end. So I will do one more class on sepsis. So we will do separately because sepsis is a huge part. So we need a separate day for that. So this is the any doubts you can ask me now. So even if you want, you can ask me in the WhatsApp or any mode of communication is okay. I think that's the end.
Some PDF ටික දාන්න පුළුවන් ද group එකට?
Yeah, I will put it. I will forward to Midusha.
Okay.
Okay, thank you. Thank you. Good night. Have a good day.